irritable bowel syndrome and abdominal spasms. Our speaker is Dr. Eric Mwenda Murunga. He is a consultant physician and a gastroenterologist. He has a clinic at the Gastro Liver Center that is located in Doctors Park building next to the Aga Khan Hospital. Part of his credentials is that he did his undergraduate degree at the University of Nairobi, did a Master of Philosophy in Gastroenterology at the Stellenbosch University in South Africa, and is a member of the American College of Physicians, a fellow of the American College of Physicians in the US. Today's topic is bound to be very interesting. Irritable bowel syndrome is one of those conditions that sometimes can be very amorphous and very vague. I am very excited about today's presentation. Dr. Murunga, if you're in, you're very much welcome. You're free to start.
Thank you very much. So I think we can get on with it. I'm trying to start the video and do screen share, but let me try to do the screen sharing. Is that visible for everybody?
Yes, it is visible.
Okay, excellent. So thank you very much to the organizers and Dr. for the kind introduction. So I'm a patient gastroenterologist, and today I was asked to speak on a topic that is around us. It's with us. I think all of us have seen patients either with or what we thought was IBS, irritable bowel syndrome, or suspected. And it is something that we deal with every single day. I'm sure all of us have seen patients with this. So it's a very interesting topic at this time that I think really deserves this time so that we can address it and discuss how the best ways to go about managing this. Specifically, the topic is hyoscine butyl bromide, which is one of the key drugs that is used in management of IBS. As you know, IBS, most of what we do, we want to make sure the symptoms are well controlled. And I would like to start by discussing a case, talking about a patient whom I've actually seen, so that we can just walk through his journey and so that we can see what we can learn out of that before we go into the actual topic of discussion. And so the plan is to discuss, to do the case report, and then osmotics in general, some specifics about hyoscine. But I think the gentleman from Sanofi will talk about the drugs in more detail, especially the basket. And then from there, I think we'll go into the main meat of the discussion today, irritable bowel syndrome, starting with the definitions, which, as you know, there are several. We can discuss the classification, epidemiology, and what features are there in this condition among the patients who suffer from it. Pathophysiology of this condition, I think this will help us to see how to approach it and the various ways in which we approach this condition and understand why we do it that way and be able to offer better care to our patients. Then management, we look at that specifically discussing evidence-based studies, you know, the guidelines. I think international guidelines help us because they're able to sift through all the evidence. And then finally, we have a brief conclusion in our talk. So to start off, this was a young man who I saw, 15-year-old male, and he presented with sharp upper abdominal cramping pain for 6 months. Pain was he had complained of constipation. A week, but most of the time, the bowel movements and the stools were hard, causing a lot of difficulty. When the pain initially started, he was treated elsewhere for positive.
Dr. Murunga, sorry to interrupt, but your audio is on and off.
Okay.
Dr. Murunga?
We were talking about there's probably a bit of feedback.
Maybe somebody can mute. Somebody should mute from that end.
Yeah, you probably need to disconnect the initial connection, Dr. Murunga.
Yeah. Is that? Yes. So basically, he was found to have H. pylori. This was treated. Then he came in for follow-up. He denies any symptoms of seeing blood in the stool, any weight loss, or any use of non-steroidal anti-inflammatory drugs. And when he came in, we did an abdominal. We sent him for an abdominal ultrasound, which was normal. And he had started lactulose and fiber supplements, which did not relieve the symptoms. So just additional history about this patient. He's a high school student, and he was found to lately have lost interest in sports and physical activity, but he plays video games regularly. So he sounds like a typical teenager. Tends to keep to himself with few friends, if any. He denies any weight loss, but his mother, who was present for most of his appointments, felt that his weight had plateaued. He wasn't gaining weight as she expected. No nocturnal symptoms of pain or any cramping at night. And just to mention that I've seen him very many times, because with IBS, it's one of those conditions where you have to really have a good relationship with these patients, because it's a long-term issue of managing it. Unfortunately, we don't have any quick solutions, as you will see. And a lot of times patients, you have to see them on a regular basis and establish trust and see how you can work your way through those symptoms. He lives with his family. His parents take a very active interest in his health. Always came with his mom. No drug allergies, non-smoker, no alcohol use, no significant family history or past medical history. On physical exam, there was no distress. He looked, fine, just mild epigastric tenderness with a flat mood and affect. The rest of the exam was unremarkable. We did some lab tests, which were generally fine except for a slightly elevated bilirubin. And H. pylori was again negative for the stool, and FOPT for calf blood was negative. So generally unremarkable. So our diagnosis was IBS C, that's constipation predominant, with the dysphoria. And we started him on initial treatment with a PEG-based laxative and Spagular psyllium husk fiber supplements initially. So as you can see from this cartoon, we normally try to have a diagnosis for every patient and they can fear it. Subsequent management. Now, we ended up doing a CT scan due to his persistent symptoms and significant tenderness that resulted in later visits, which showed heavy colonic fecal loading, but no other abnormalities. On follow-up, there was no change in the symptoms, despite the PEG laxatives and the psyllium husk supplements. And therefore, we decided to start him on a diet that is low in FODMAPs, which we will discuss in one of the later slides. And the PEG laxative was increased from once to twice a day and later 3 times a day. 1 week later on review, there's still no change. We started on linaclotide, which, as you'll see, it's a good medication that is a laxative, somewhat new, not yet easily available in Kenya, but specifically designed for IBS. And PEG was reduced to once a day. When he followed up, his pain was still only slightly better. He was passing stools slightly more often, probably 2 to 3 times a week now. And we decided to start him on Buscopan, hyacinth butyl bromide, or HBB, 10 milligrams as needed, with significant improvement in the symptoms. Upon follow-up, His stools were softer. There was less nausea and pain, but we still go 3 to 4 days without stool. Still looked, very flat affect. I don't know if you've seen these teenagers who just look bored and, you try to talk to them, you ask a question, they're just looking away. That's how he was. So then we realized he'll probably benefit from seeing a psychologist. And we asked the patient and their parents to see one. We did an appointment for them. And sometimes in cases like this, it might actually be okay for patients to see do like just a family visit, not just a patient alone, especially at this age, sometimes even with family members. And the idea is that this, issues could be, part of it could be maybe a lot of stress from the parents, helicopter parenting, a lot of demands, and all those things can be addressed in addition to whatever, psychological issues that the patient might have. So, and we'll see further as we continue why this is something that could be of benefit in IBS. The pain was previously 10 out of 10 when he came, but by the time we saw him, it was 3 out of 10, according to the patient. This was the first significant improvement in his symptoms. Current status, he feels much better on subsequent visits. I've seen him actually for a few years, and, you can gradually see the improvement. He's happier. He says the PEG laxatives seem to work better for him than fiber. He still goes 2 to 3 days between bowel movements as opposed to 5 to 7 days previously, but he feels that his quality of life is better and he's able to concentrate in his schoolwork. He really feels normal once again. He's been encouraged to exercise more, take part in social activities, and just try to address any of the psychosocial aspects of this condition which are there. So the patient and the family understand that this is a long-term journey with a focus on quality of life and overall well-being. It's not one of those diseases like malaria, you come, you're given medication and it's over. So this is a discussion which definitely we had with this family, and made sure that everybody understand that we are in this for this is a long road, it's a journey that we have to take together. So now, having talked about our patient, just brief discussions about antispasmodics in general. And these are medications that address symptoms caused by gastrointestinal spasm and dysmotility. The two main broad classes of antispasmodics are antimuscarinics, such as otilonium bromide and hyoscine. These reduce intestinal motility predominantly. They also do relax the smooth muscles. And then there are those, number 2, you have the direct smooth muscle relaxants, such as mebeverine. Now, hyoscine is a drug which was first registered in Germany in 1951. And it is a derivative of hyoscine. HBB is a derivative of hyoscine, which is extracted from the leaves of this Duboisia tree that is mainly found in Australia. So it's actually, a few small areas in Australia where they do a lot of farming of this, and there are big farms, and these drugs can be obtained from that. It's an anticholinergic agent, quaternary ammonium derivative. That is a structure for those of you who like this. I'm sure Dr. Mildred and the other pharmacists on board, they know all about this. And for the rest of our audience, I'll give you a minute to memorize it, and we'll ask about it at the end of the talk. All right. So how does this medication act? It is, as I said, an anticholinergic / mainly antimuscarinic agent, although it has anti-nicotinic properties. It does not cross the blood-brain barrier, and the plasma protein binding is low. Most of the drug is metabolized in the liver. It blocks the action of acetylcholine at parasympathetic sites in smooth muscle and the secretory glands. Therefore, you can get both benefits of reduction in motility in the GI tract and the urogenital tract, as well as reducing secretions from the digestive system. Previously was used more in the anesthesia. Now they have other drugs which they use to reduce secretions. But because of these properties, it is used primarily in gastroenterology to reduce and treat the spasms caused by people, as you know, who have GE, people who have colitis from either infective or other causes. Then in IBD, inflammatory bowel disease, diverticulitis, biliary colic, cystitis, urinary colic, and primary dysmenorrhea. It is also used to prevent spasms of the GI tract prior to invasive radiologic and diagnostic procedures, such as ERCP. In patients who are in the ward and they have a lot of secretions, especially at terminal patients at the final stages of life, that uncomfortable rattling, what they call the death rattle, can also be treated using this to reduce the secretions in the airway in that setting. What are the indications? So as we've discussed, it can deal with abdominal pain from many uses, non-specific abdominal pain, especially in young people, from causes such as, menstrual periods, from IBS. It's liked a lot by the urologist for renal colic. And during ERCP procedure in gastroenterology, we do use it to prevent or reduce the peristaltic movements, because sometimes if you're trying to cannulate the bile duct and there's a lot of movement around, first thing we ask for is Buscopan, and we're able to get that sorted out. So during anesthesia induction, as I said, diagnostic aid in radiology, like patients getting some MRIs where they don't want too much movement of the bowels, or barium studies, it can be used. What are the contraindications? With any drug, hypersensitivity to the medication. For this particular one, any mechanical stenosis or achalasia of the digestive system, ileus or megacolon, BPH with urine retention, because it can actually worsen that retention of the urine in these patients. So you want to be careful which patients you're giving it to. If you have a patient with some of these symptoms, they're elderly, male, and is suspecting some of this. I mentioned it because it's common. Or ileus, we've talked about, it's also a little common. Myasthenia gravis, I don't get to see a lot of this, so I don't think it's very common, but you have to be aware of that. Glaucoma, and cardiac patients who have tachyarrhythmias or in heart failure, then you have to just take that with caution. Drug interactions. Generally, drugs with anticholinergic effects like tricyclic antidepressants, antihistamines, and antipsychotics, ipratropium, tiotropium, these can potentiate the anticholinergic effects of this medication. And dopamine agonists like metoclopramide can antagonize the GI effects of HBV and render it less effective for what you're trying to achieve. What are some of the adverse effects? We talked anaphylaxis or hypersensitivity, and urinary retention, increase in intraocular pressure. These are things that are possible side effects for this medication. And I'll just mention a little bit about some of the studies found that help us to be able to recommend this medication, hyoscine, for IBS pain. There are 3 randomized controlled trials which were recently assessed, and the 426 patients in total, so quite a big study. And there was a statistically significant effect on improvement of IBS symptoms, particularly the cramping. So the number needed to treat was only 3. And this is, major, evaluation by the American College of Gastroenterology. And basically, I think to me, what I want to point out is I'm not a statistician, but when I look at these studies, the statistic that really makes a lot of sense to me and is very simple and to understand is the number needed to treat. So if a number needed to treat anything less than 10 really is quite excellent. And number needed to treat of 3, I think to me shows that for sure it is doing something when you have these high quality studies telling us this, giving us this finding. And it's generally a safe and affordable drug. There was a review that came to these conclusions. There's benefit that has been found in colicky, abdominal pain, irritable bowel syndrome, labor and delivery. Perhaps the obstetricians among us, comment on that. And then dysmenorrhea and renal colic. So for GI, we prefer the oral and parenteral for spasms and other symptoms because the oral is not very highly absorbed. But for instance, in ERCP, we use a lot of the parenteral drug, but these other indications, more of the oral formulation. So I think now I will happily step on to discuss IBS and how we can manage this and just talk a little bit about this condition. Irritable bowel syndrome, or IBS, is a functional disorder. It is associated with increased healthcare costs and frequent absenteeism from work. So it doesn't always look like a very serious issue. But if somebody is not going to work, if somebody, is so disturbed that it disturbs their quality of life, then I think this requires our attention. The global prevalence is estimated to be 11%, both from there are 2 studies. There's a meta-analysis of 80 international studies with 260,000 subjects, and from a European telephone survey covering 8 countries. Now, what we note is that, there's some studies that show even higher prevalence, but there is a reduced prevalence of IBS in the rural settings. So in studies done in Africa, for example, in South Africa, they found if you compare people living in rural settings versus in urban centers, it's more common in urban centers. And so that is, probably something that we would see here, that, it seems to be, and it's not very clear why this is so. Is it that people in urban centers are, they're more keen to look at their studies, or maybe they get bothered by this, and there's a psychological aspect of it. Could it be more stress in these areas? So that, I think, will need to be looked at so that we can understand why that is. Now, it's very important to have an idea about the definitions, because there are several definitions out there. Some are simple, some are complex, some are designed more for research studies. A lot of times, if you have a patient with you, you can have an idea whether they have IBS or not, because sometimes it's like a sense, you can sense, but it's always good to have definitions and just something to help you really, because what sometimes happens is that there are patients with other organic conditions who may be labeled as having IBS. And we will see how to avoid some of these pitfalls. If somebody might have an infection, somebody might have H. pylori, it could even be serious enough that it's a tumor. So we don't want to just label everybody that they have IBS, but we want to really get a good understanding of how we can make this diagnosis. There was this simple diagnosis from the American College of Gastroenterology. It's just simply abdominal discomfort associated with altered bowel habits. So very simple, diagnosis, or very simple definition, so that you can start thinking about it when you have discomfort associated with altered bowel habits. But there are many things which can do this or cause these symptoms. The first published criteria was a Manning criteria published in 1978. And that's the first time I think people started to think about this in a more positive way instead of thinking about it as a diagnosis of exclusion. That's when people said, what can we do? What criteria can we use to say that somebody has IBS?
And it is still, as much as it's old and it was the first one, I think it still has a bit of a role, so that if you see a patient with some of these things, you start thinking about IBS. Abdominal pain, which is relieved by defecation. I think this is what most people are aware of. But now, the newer definitions, as you'll see, the pain may not be relieved by defecation. It might be worsened by defecation. So it might be made better or worse. So we say association with bowel movements. But initially that was, because this is the most common thing that it gets relieved by defecation. Then the other thing is they notice the stool also gets loose with the onset of pain. So the looser stools with the onset of pain, that's part of the Manning criteria. More frequent stool with the onset of pain. So frequency also was addressed. Abdominal distension. So in as much as many people with IBS have abdominal distension, now you'll find that it's not a very critical part of the criteria because not everybody has that. But at that point, that was noted. And I think what this helps us is also to think about these symptoms, because these are the common symptoms, basically, people who come in with IBS. Passage of mucus in the stool. So a lot of times, it's not that they have mucoid stool. It's not, nowadays, it's not like the most major, one of the big points that you think about in the definition, but definitely can help you think about it in these patients. Then a sensation of incomplete evacuation or tenesmus, common finding in IBS. Then, after the Manning criteria, there was a group that was formed called the Rome Foundation. So they started trying to come up with criteria that they felt was more reproducible and was a better way to have a diagnosis of IBS, particularly in the research setting. Although, a lot of the guidelines recommend using it in clinical findings, but this is now what we ended up with the Rome criteria. So there was Rome 1, 2, 3, and 4. So the most recent one is the Rome 4 criteria. As you can see, it was first published in 2016, so it's still a few years down the road. Maybe they'll do another meeting and give us the Rome 5, but for now, this is what we have. And the Rome criteria covers all kinds of functional GI conditions, including esophageal conditions, functional abdominal pain, and all of that. But what we're interested in today is the Rome 5 criteria for irritable bowel syndrome. And they were very clear that there should be recurrent abdominal pain 1 day, a week, or more in 3 months. So at least every week, somebody should have this pain. It's not just get it once a month. No, it's not IBS. At least once a week. Most people will have the pain more often than that. But in the last 3 months, they should be at least weekly. And the onset of these symptoms should have been 6 months prior to coming in to see it. So it should last for 6 months. Then the pain is related to defecation. So it could either be more pain or less pain with defecation. And then the third point is change in stool frequency. So it might either be loose or hard. You remember with the Manning criteria, they were thinking more of just the loose stools. But right now, it's been recognized that it could either be hard or loose. And then, sorry, that's the frequency. I'm talking about the frequency, but change in stool form and appearance is where it could be hard or loose. But the frequency, most times it becomes less frequent, but usually when there's diarrhea, it might be more frequent than what one expects. And then the other very important thing, which we don't always talk about in this criteria, is the lack of warning signs, or what we call alarm symptoms. But with the signs, you include other things that we'll talk about. So the other criteria which has been there is from the UK, the NICE guideline definition for IBS. And here they don't talk about the once per week, they just talk about pain or discomfort, altered bowel habit, at least 6 months, and no alarm symptoms. So you can see it's very simple. They don't talk about how many times per day, form, appearance, just that, if there's a change in the bowel habits, be it less frequent or more frequent or loose or hard, there's a change in the bowel habit. There's abdominal pain or discomfort. It doesn't even have to be pain. It might just be discomfort. And then for at least 6 months, without alarm symptoms or signs, then that is can be considered by this nice definition to be IBS. And frankly, it's more practical for clinical use because you have a busy clinic. You're trying to recall, was it once a week or twice a week? You know, it gets a little complex. But when you have something as simple as this, then you can easily make a positive diagnosis of IBS. So what are the warning signs that we need to be careful about? Age greater than 45 years or more with no prior colon cancer screening. So somebody who is 45, I used to think 45 was a very old age until I passed that age. So I don't know how many in the audience still consider that as a very elderly man, or woman. So if somebody is this age, they have no prior colon cancer screening, then you cannot really say that this person has IBS until you're sure what's going on. I don't know if any of you have seen, patients diagnosed. The most common thing we see is H. pylori. Patients have been diagnosed with H. pylori, but they have some of these symptoms. They've been losing weight, and they're older. Especially in the old people, if you start seeing anything odd, you've got to really assess them properly, thinking of cancer. So when you're talking about warning signs, you're thinking of serious issues, primarily cancer. So we want to make sure we don't want to miss this in any of the patients that we label as having IBS. So if there's a recent change in bowel habits. So of course, they're talking about 6 months. By the time these patients come and tell you about IBS patients come and tell you that there have been bowel changes, believe me, it's going to be far longer than 6 months. Some people will say, since high school, I've been having these hard stools, or for the last 3 years, I've been having these loose stools. That is a bit more reassuring. And that's why they try to give a cutoff of 6 months, as opposed to a patient who, if a patient just, I was fine, but, 2 months ago, I've just been having hard stools, then you need to assess that, especially if they have some of these other things like weight loss and all this. Then overt GI bleed. Some patients may say either they have black stools or they see blood in the tissue. And I know a lot of patients will try to minimize it. And they say, oh, it's just because of these hemorrhoids. That's why I see blood in the tissue. But any amount of blood for whatever, even if the cause is a very obvious hemorrhoid, you've got to assess it. Because if somebody has a hemorrhoid, it doesn't mean that they don't have some other problem, It could be that maybe there's a tumor in the colon that is making their stools harder to pass, and now they've developed a hemorrhoid. So we cannot ignore even a drop or even just a trace of blood in the tissue. And as the last point you can see there is occult blood test. If it's positive, then we need to be able to say, look, we cannot take this lightly. We cannot just label you to have IBS. Let us rule out other big things. People who have pain at night, or they wake up at night to pass stools, then you need to assess them. It may not be malignancy, but it could be an infection. It could be maybe amoeba or whatever other issue, but still something, it needs to be checked. Unintentional weight loss. A lot of patients, even when you talk about intentional weight loss, if a patient, many people, as you know, it's very hard to lose weight. If we tell a patient they need to target a weight loss of 10 kilos, very few will make it there. But sometimes you might find a patient is just too successful at losing weight, So it may be intentional, but they're just too successful. Then, sometimes also we need to think about that a little more. And I remember a patient was like, are you not happy with my success? But look, you can't just randomly come up and I tell you to lose weight, or you decide you want to be healthy and you go and lose 15 kilos and everybody else is losing only 2 kilos, they might need to be looked at, especially if there are other issues going on with these other warning signs that we're talking about. Family history of colon cancer or inflammatory bowel disease. So inflammatory bowel disease, like Crohn's disease, ulcerative colitis, these are things that used to be considered rare, but we're seeing more and more Africans getting these conditions. So it's not like before where you just consider it a disease of Western countries. So if there's history of that, if there's history of colon cancer, or even family members who have had large colon polyps, then that is a warning sign that this patient might require colonoscopy. Palpable abdominal mass or lymphadenopathy on examination. So a good physical exam is essential with this as with any other medical condition. And if you see something like that, then you need to assess that, be it scanning or whatever else is appropriate at that point. What about patients who come in, we've mentioned occult blood, but they may not even have noticed bleeding, but they have iron deficiency anemia when you test. They have, sometimes the MCV might be a little low or the HB, so that cannot be ignored either. We need to pursue that further. Okay. So as far as classification, I think this is something which, most of us are aware of. There's IBS-C, that is constipation predominant, IBS, diarrhea predominant. There's a mixed type and unclassified IBS. Now, this slide will help us. Do all of you have this Bristol stool chart? It really sometimes can help. I won't lie to you that I show it to every patient, but ideally, sometimes some patients have difficulty describing. So type 1 and 2, this is definitely constipation. And you'll find that the definition here, the key word here is 25%. If there's 25%, more than 25% or more hard stools, and then diarrhea less than 25% of the time, that is IBS-C. If it's the opposite, where you have more than 25% loose stools and less than 25% hard stools, that is IBS-D. But then in the middle, you might have, they're not fulfilling these percentages. Both are more than 25%. That is the IBS-M, or the mixed pattern, which is illustrated more with this slide. So unspecified. So IBS-M, both are more than 25%. So it's like almost half the time you're either having diarrhea or constipation. That's a mixed pattern. You can't tell which is more. Or if really the stools are generally normal, and but they have IBS, you still feel there's IBS per the criteria we've talked about, but there's most of the time it's normal, but less than 25% hard and less than 25% loose, then we call that IBS unspecified. So these are 4 categories of IBS. All right, what is the pathophysiology of IBS? Now, this is something that's very poorly understood. And a lot of times, if you talk to a patient or if you discuss it, you don't want the patient to get the feeling that you're saying it's all in your mind. Because, if you start saying there's nothing wrong with you, it's just, you don't want them to think that it's all in their mind, because people feel dismissed. If you tell them that you're okay, wewe tu ndio unasikia hivyo, somebody might feel dismissed, that really you don't think I'm really sick, you think I'm just malingering or something like that. So I think it's important for them to know that in as much as we are not able to do, find a lesion, that is obvious, it doesn't mean that it's in your mind. It's a real issue. It's a real problem of the function of the digestive system. So it is poorly understood, and it is thought that one might be predisposed by genetic or epigenetic effects, infections, or adverse life events earlier on. I think sometimes you may have noticed somebody probably was well until they got, a GE episode, and you treat them and they just don't get better. And IBS can actually creep in something like that. Stressful life events, maybe a child going to boarding school, maybe there's trauma there or something else happening. But that's why we mention there's a correlation with, psychological aspects that we'll mention as we proceed. Stress and poor coping mechanisms may worsen the symptoms of IBS. So that's something to think about. So it could probably trigger, but also worsen the symptoms. So psychological comorbidity may result from IBS because these things, when you have to have, abdominal pain and can't pass stool for a week, it can honestly cause stress to anyone. And it can also lead to IBS. So you might find the stress itself is leading to IBS, becoming a vicious cycle. You may have noticed that a lot of IBS patients, like the ones in boarding school, especially when they're in school, they're very sick, they're always constipated, or they're always having diarrhea with pain. But the minute holidays come and they're at home and they're more relaxed, then they feel better. Or even adults who are working, when you're here going to work every day, you get more IBS symptoms. The minute you take a break and go to Mombasa to relax or to Naivasha for Safari Rally, the symptoms improve. And a lot of this is thought to be as a result of the bidirectional communication between the gut and the brain via the brain-gut axis. You all know about the enteric brain, all those nerves in the digestive system. And when there's this communication, one might cause problems in the other. Both can cause problems. Both the brain and the gut can affect each other adversely, leading to IBS. So in summary, these are the 6 main theories that are thought to explain why IBS exists. Number one, there could be autonomic nervous system modulation problems or CNS modulation that can affect, IBS. Altered visual perception plays a role in the pathophysiology. GI transit and motility has a big role, and this is one of the areas that we're addressing with the HPB or hyoscine. Immune regulation, inflammation, and epithelial permeability also play a role. You'll find, issues of infection and antibiotic use, which we'll discuss. What about the microbiome? A few years ago, this was the hot topic in gastroenterology, and every meeting you'd go to, half the sessions were about the microbiome, and every talk had something to do with the microbiome. And it still has a role, it's still important, and there is also thought to be somewhat of a role in IBS. Now, the hot topic in gastroenterology is artificial intelligence, and I'm sure that's probably hot in every specialty. So lastly, genetics and epigenetics play a role. And let's go on and discuss each of these briefly. When you talk about CNS and autonomic nervous system modulation, the signals from the gut are modulated by emotional and cognitive factors that result in IBS symptoms. Like somebody is stressed, they're very anxious, that worsens it. Cognitive factors, how do you perceive this? I mean, do you think that there's a big problem or things are very serious? That makes things worse. Altered brain regions have been seen in IBS patients. Those areas which are responsible for cognitive and emotional responses in the brain, when they scan the brains, they've been altered. So it shows that there's abnormality that might be inherent in these IBS patients. And then the result of all of this is that when these brain regions are altered, they might end up now with a patient having visceral hypersensitivity. So the same amount of intestinal distension in an IBS patient and somebody else with that IBS can cause worsening symptoms. In fact, sometimes they even do balloon tests where they put a rectal balloon and inflate. And you'll find there might be visceral hypersensitivity in IBS patients. It really bothers them when you do the same volume and somebody without IBS, the same volume may not really bother them. They can continue without that hypersensitivity. And hypervigilance might result. They're always on the lookout. They can't relax. And that makes everything worse. So in IBS, it was also noted that parasympathetic activity may be reduced and sympathetic activity might be increased. So it's kind of like a stress mode affecting the autonomic nervous system modulation. So both CNS and ANS are involved. What about the perception? There's a study that found 20 to 60% of IBS patients have enhanced visceral perception to various psychological stimuli, be it mechanical or electrical, such as the balloon, things that I've talked about. And there's higher sensitivity that correlates positively with symptom severity in a multicenter study, which was published a few years ago. When you talk about transit and motility in being involved in the pathophysiology of IBS, it's not to a huge degree that you'd expect. So I mean, every IBS patient has motility issues, but there are some who were found to have abnormalities. In IBS-C, only 10 to 20% of the patients had transit abnormality. So even though they're presenting with constipation, I mean, the primary issue is that there's decreased transit time. But in IBS-D, there was a higher percentage of 25 to 45% that were found to have rapid transit. So this shows that yes, it would probably play a role, even though not in everybody. And then when they were actually able to test these contractions, they found that high amplitude propagating contractions in patients with IBS-D are associated with abdominal pain. So this is a situation where just because of kind of hyperexcitable colon that caused the diarrhea, the same movement also is associated with abdominal pain. Hence, these are patients who would likely benefit from antispasmodics. Then what about immune regulation, inflammation, and epithelial permeability? So they've actually tested and found that the numbers of mast cells are increased, especially in the descending colon and rectosigmoid area, and in the small intestine in IBS patients. So this is the most consistent finding, just those mast cells. You don't get too much of the lymphocytes and those other things. But then they found that actually having those mast cells correlates with the frequency and severity of pain when those mast cells are activated, especially in close proximity to nerve endings in the gut mucosa. So this appears to play a role in the symptoms that patients get. And when there's increased permeability in patients with IBS-D and the visceral sensitivity, there's also correlation to that. And the symptom severity. So these are things when there's permeability, patients, I'm sure they, about patients on the internet now, the leaky gut, everybody says they have leaky gut. So leaky gut is like a fashionable word that patients Google and come and tell you about. And, they might have a point. They might have a point. The microbiome. So evidence supports the role of bacterial, viral, or parasitic infections as a trigger for IBS. We talked about that patient who gets GE, and after that they are no longer well. They continue to have symptoms for years. So antibiotic use might actually improve IBS symptoms. Things like rifaximin and other antibiotics can actually, and we'll see later when you talk about the treatment, that they can actually help. But some antibiotics can actually trigger IBS symptoms. So this is something that has been found and documented, definitely suggesting that the microbiome has a role in this condition. So as you can see, the multifaceted condition, there are many different things that play a role in as much as it's still poorly understood. So changes in the gut microbiome can modify GI motility, that is something we know, visceral sensation, intestinal permeability, stool consistency, and visceral sensitivity. Genetics and epigenetics. So we do know about familial clustering of IBS. You'll find sometimes when a mother brings her daughter, she'll say that, the mother also, when she was a teenager, things were very bad for her. So this suggests genetic and possible environmental factors. There is some evidence for epigenetic changes in IBS, including alteration in DNA methylation. Various miRNAs appear to be associated with increased visceral sensitivity and permeability. And this was a study published recently that gave evidence for that. What are the features of this? So as we've discussed, it's more common in women and young people. I see it quite often in high school girls who come in with constipation. They'll give you a history where they often have to go to the emergency room and get enemas, and it can really be traumatizing for them. So there's some studies that have shown a 10 to 20% prevalence in the age group of 20 to 30 years. So twice as common in men as women. So patients often get low abdominal pain, and bloating is common. So that's why, like we're saying, if an older person comes, not to say that an older person can't have IBS, but I hope everybody can hear me. So can you all hear me? I'll just continue. I'll take that as a
Yes.
We can hear you, Doctor.
Thanks. Awesome. Now, so in managing, we talked about doctor-patient relationship. It's very critical. We've seen it with the patient I mentioned. A lot of times, before you can sort the issues of a patient with IBS, it will
Dr. Eric, I think your connection has dropped again.
and the CRP, because if the CRP is high, this patient has pain. Could it be appendicitis? Could it be something else? If they're anemic, then obviously you have to just quickly assess that, consider endoscopies and colonoscopies and all of that. Fecal calprotectin. Now, this is a very good stool test, which is immunological, and it can show if a patient has irritable inflammatory bowel disease, ulcerative colitis, or Crohn's disease. In as much as these conditions are not as common here, this recommendation, and a lot of times it's important to look at recommendations in our context. These are recommendations from Western countries because we don't have local recommendations for IBS. So we don't see as much of IBS or IBD here as they do out there. So there it's kind of fast, like you've got to do it in everybody. Here, it's not a must really do it in everybody, but it's something to consider because we're still getting this case, especially in, because both IBD and IBS are conditions that can be there for years. Celiac disease, again, that one is even more rare locally among the African population. In the West, it's more common, and for them, it's kind of first line to test for that. Here, frankly, not a first line test. Then it's important to ensure the patient, especially at the age of 45. We used to say 50 years, but now, as you know, screening for colon cancer starts at 45, perhaps even younger, perhaps even as young as 40 years in our African population who tend to get it early. I recently diagnosed it in a 23-year-old advanced colon cancer, so on and on. I had a 29-year-old patient die of colon cancer. So these things are not rare, they can happen. And all of you in the audience, please make sure you've been screened, at least at a very minimum with stool occult blood test, if not a colonoscopy. Because sometimes as medical people, we tend to forget ourselves, and many people don't get any screening at all.
Dr. Murunga, I think we've lost you again.
If you have H. pylori, it doesn't mean you have something else. So you can have H. pylori and IBS. Somebody can have H. pylori and some other condition. So many times, I think the problem is not so much that H. pylori has become endemic, but the issue is, if you do a test, somebody can come with a fracture of the arm, and you do H. pylori and it's positive, doesn't mean you forget about that fracture. That's not the cause of the fracture. Yes, it's there, but that's not the issue today that the patient has brought there. And I say this to illustrate because, you know, I have seen a patient who was clearly jaundiced and had lost probably 10, 20 kilos. And just because H. pylori was found, everything else was forgotten. Nobody thought to figure out why they have jaundice, and they saw some people and they forgot everything else and focused on H. pylori. That's where the problem comes in. This patient perhaps should not even have been tested for H. pylori when they come in with jaundice and weight loss. So H. pylori, I think that's why it's getting a bad rap because of those sort of scenarios. But in a situation like IBS, really, it's important to test and treat for it. The other thing which has come out in this recent guidelines which are being adopted, there's this 2021, very recent from UK. There's the US guideline, which I'll refer to as we continue. That's a very recent one from 2022, literally last year. So fresh out of the oven. And the emphasis in all of this is it's a positive diagnosis. Try and make a positive diagnosis. Use those criteria that we talked about to try and make a positive diagnosis, not a diagnosis of exclusion. So it doesn't mean, in as much as you're saying, yes, do the hemogram and check for H. pylori, it doesn't mean now that you must go through all the conditions. And then when everything is negative, that's when you say, no, not everybody needs a colonoscopy if they have IBS. But if somebody has warning signs, please don't forget, just because you think they might have IBS, but they're bleeding or they've lost weight, please, those ones need to be sorted out. So it's a very fine, it's kind of fine tuning of our approach, kind of trying to end up with precision medicine, not casting the net everywhere and hoping to hit something, or shooting everywhere, hoping to hit something. But, you know, kind of try to be precise about this approach. All right. Now I will talk about, as we continue, just those things we talked about, psychosocial health and IBS, because it is important. Our patient was clearly a stressed teenager. So this young man, you know, he doesn't meet your eyes, and we've all seen that. Part of it is adolescence, you know. I don't know if you remember how it was being an adolescent, but I'm sure you see them now and you think you were never like that. But part of this is adolescence, where, you know, what is normal, what is abnormal. But sometimes, you know, it just strikes you. This person, you know, there's something, he looks stressed, cannot even meet your gaze. And sometimes this can be a finding of psychological disturbance, which has been associated with IBS. So if patients come with these symptoms, think about that. And there's actually been found that cognitive behavior therapy is of benefit. So in this kind of patients, try to talk to the psychologist where you feel they might benefit. Some of it might actually have frank depression and might actually require to be on antidepressants. And you'll find that 40 to 60% of IBS patients have comorbid psychiatric diagnosis. So that's a very huge number. 38% of IBS patients actually contemplate suicide as a result of their symptoms. This is a ridiculously high number, and something that really should make us say, look, if you see IBS, don't forget that other thing, that other side of things that could be making more wise, because you want to treat the overall health of these patients. Then IBS patients also report a lower quality of life than patients who have more, or what you put in quotes, more serious conditions like end-stage renal disease and diabetes mellitus. So can you imagine that? IBS, sometimes we tend to dismiss it, but their quality of life is worse. You know, they just can't cope, can't go to work, absenteeism even from schools. Often patients are brought in by their parents from school because, you know, they couldn't continue their studies, and this affects their quality of life, and they just constantly feel sick, and you end up with a sick child syndrome. And even with adults, you know, it contributes a lot to the stress. So very important point that I don't want us to miss out. Now, what are the first line treatments for irritable bowel syndrome? Regular exercise. So simple as it looks and related as it looks, you know, we told our patient, look, leave those video games, go out there and run with other children, play football, do all those things, exercise. And even for grown-ups, sometimes just, you know, walking regularly or going to the gym or doing some sports, that can actually make you 50% better, make your patients 50% better with regards to IBS. What about the low FODMAP diet? You see, there are many diets out there which have been proposed for IBS, and you know, but this is the one that has been really found to be reproducible and has been validated, and it seems to work. It's a bit complex though, but the FODMAP refers to fermentable oligosaccharides, disaccharides, and monosaccharides and polyols. So these are things that make people feel bloated, and generally, ideally, it's supposed to be something that the patient sits with the dietitian to go through it, because it can be complex. Sometimes that's not always practical for one reason or the other. So I personally, you know, have printed out a summary and try to discuss it with the patient. And you tell them, look, it might be restrictive, but it's something that they would have to just follow for maybe 1-2 months, at most 3 months. And then after that, they reintroduce one food at a time. So then they feel reassured that they're not going to be on this diet forever, because you know nobody wants to feel restricted for a long duration. But once they understand that it's probably just a short-term thing, then they can be more motivated to try and follow it. And the idea is, if they can follow it for 1 to 2 months, and then after that, try to reintroduce one of the foods that they miss one at a time, then you might find out of this whole diet, maybe only 2 things are causing problems, and they can tolerate the rest. So that really helps the patient to live a better quality of life with you know, limited changes in their lifestyle. One of the main things in this low FODMAP diet is beans. So, you know, I know a lot of people like githeri and beans. People from the mountain, I don't know if you tell them to avoid beans, what they'll say, but you tell them, look, it's only for a month, tujaribu tu, and that can help. Then, and we'll talk a bit more about this low FODMAP diet. The other first line, so low FODMAP, regular exercise, those are first line. Now, then you go symptomatically. A patient is having diarrhea. Imodium is a very good drug, or loperamide for IBS with diarrhea. Some people end up having to take it on a regular basis, twice a day, or PRN, but it can actually help, and it's very safe. They can take as many as 8 tablets in a day without major issues. Antispasmodics, such as Buscopan, for global symptoms and abdominal pain. So not only for the pain, even for some of the other symptoms that the patients will feel, like bloating and all this discomfort. And it's indicated for both IBS-C and IBS-D, according to all the guidelines. And the other one that helps for pain is peppermint oil in specific formulations that are indicated for IBS. As far as IBS-C for constipation, the PEG or polyethylene glycol osmotic laxatives, which are available in the market, those are found to be really good and safe. Make sure they're not using this other, you know, Senna and this other stimulant laxatives. So PEG is an osmotic laxative, so this is safe for long-term use. But patients a lot of patients will go and buy, you know, Dalcolax and all these other, you know, paraffin, all kinds of things. Some oil, I don't prescribe it, but it's very popular. But you know what I mean. There are a lot of those drops, Skilax, all these stimulant laxatives. Please avoid them. They can cause complications in the long term. But for PEG-based laxatives, those are actually the best for this. Now, just a brief on the low FODMAP diet. So the first column is safe to eat. This other one you avoid. So avoid garlic, beans, onions, avoid certain foods like watermelons, which are very popular, even avocados, a lot of cauliflower, cabbages, all those should be avoided. Certain types of peas and mushrooms should also be avoided. Beans, for sure, we've said those need to be avoided. You can see them at the bottom. A lot of starches, wheat bread. We talked about avocados and some almonds, sausages. All these things should be avoided. So on this side, you have some of the ones which are better. So apples also, they didn't put them here, but apples are also high in FODMAP, so you have to avoid those. So in this case, an apple a day will not keep the doctor away. So soybeans should also be avoided. Milk should also be definitely reduced as much as possible. So it can be a restricted diet, and a lot of times you have to take a dietitian to sit with them. You need to make sure your dietitian is on the same page as you. Make sure you're sending the patient to the dietitian. Discuss with the dietitian about low FODMAP so that you're on the same page. Otherwise, they might go, and if somebody is not aware of what you're trying to achieve with this patient, they might get very different advice from what you would have recommended. So going on with the guidelines, we talked about the British guidelines. There are also these very recent US guidelines for the AGA, American Gastroenterology Association. And this was published just recently for both IBS-C, and there's another one for D, both published together. And this is what will take us now to the second line treatments for IBS-C. So the first line really are what most of our patients should be with, because a lot of them don't need these very big guns, because some of these dawas are quite expensive. One of the newest is tenapanor. It's not available here in as much as I'm aware, but it is an inhibitor of the sodium hydrogen exchanger in the small bowel and colon, and can help, especially with IBS-C. The other medication here on the list is the lecanatide. So these are patients who have failed all those other things. It's a guanylate cyclase C agonist that stimulates chloride and bicarbonate secretion into the intestine, therefore helping patients who have IBS-C. Linaclotide, the one that we were able to obtain for our patient, is also a GCC agonist, and so like I said, it's expensive. When you get it here, it's in the range of maybe 15,000 shillings per month if you're taking it once a day. So you can see this is not something that will be available for most Kenyans, as opposed to hyoscine, which obviously it's far cheaper and
Dr. Eric, your volume has gone down drastically. Check on it.
No longer used. It came in 3 years ago as a new kid on the block, and everybody thought it was going to help a lot of IBS patients, but it turned out to have some serious cardiovascular.
Dr. Murunga, you've been
Yeah.
muted. Okay,
Can
now
you
we
hear
can.
me?
Now we can
Okay.
hear. Thank you.
Okay, have I gone on for long? Do I need to go back a bit?
Maybe
Or-
the last sentence of the last slide.
Yeah,
The last
let's
two
go back.
sentences.
Yeah.
Yes. Yeah, I was talking about tricyclic antidepressants, such as amitriptyline. Usually the doses that work for this are very low, like 10 milligrams. I normally would start with 10 milligrams, or if the 10 milligram dose is not available, you can take the 25 and ask them to cut it in half, take it at night. It helps, especially in patients with IBS-D, it's like I said, these are second line drugs. So rarely do we end up using these things for IBS. It's not first line like the others we talked about, antispasmodics and the diet and whatnot. These are second line. So only in patients who are really becoming refractory. And if we're talking about amitriptyline, patients will go and Google this. So you have to have a talk with them that I'm not just saying that you're depressed, that's why you have these symptoms, but I normally explain to them that doses which are used by depression are 50 milligrams, 100 milligrams, even 150. But for these nerves in the intestine which are not functioning very well, we only need a tiny dose, and this is not going to help anybody who has depression. So they need to understand that bit because they're going to Google and probably throw it away if you don't. And even if you have that talk, they might still not buy it. But you've got to try if you feel that now this is the thing that is indicated. It can help, especially with those viscerally mediated causes forms of abdominal pain. SSRIs are no longer recommended for IBS. So if somebody with IBS has depression, yes, then you can give them fluoxetine and the other SSRIs. But as a cure or as a treatment for IBS, not indicated according to these US guidelines. Going on still with the second line treatment for IBS-D, one of the very good treatments is rifaximin at a dose of 550 milligrams 3 times a day for 2 weeks. And it is more effective in IBS with diarrhea. And, it's been found to help probably 30 to 50% of IBS-D patients in studies. So definitely worthwhile, worth giving them a trial of that. It's also not cheap. And if patients get better and the symptoms recur, then there's a role for retreating. Again, you could give another course of treatment. It's been found in studies to help. There's a drug that is used not very commonly, luxadolin. It's an opioid receptor agonist that can be used, especially in IBS with diarrhea. If somebody who drinks more than 3 bottles of beer per day, or who has had prior cholecystectomy, this should be avoided. Allocetrone, only approved for women, 5-HT3 receptor antagonists. And again, we talked about the tricyclic antidepressants. So this table is a summary of what we've been talking about in management of IBS. So when you're starting at the top, you've already made a diagnosis, a positive diagnosis of IBS. You have ensured that this patient does not have warning symptoms. We are not missing some tumor or something like that. If there's H. pylori, we have treated it. And then you come down this pathway. Now, one of the things you mentioned is the provider-patient relationship, education and assurance, show support, lifestyle modification, exercise, stress reduction, make sure they're getting enough sleep, dietary modification, such as increasing fiber and the low FODMAP diet. So these apply for everybody. Then you come down to the left to IBS-C. So these are mild symptoms. So you're going to go on the first line drugs. You've already done the diet and the rest. Constipation, start the osmotic laxatives such as the PEG-based treatment. Make sure they're not taking those other laxatives that we don't like, the stimulant laxatives. Abdominal pain should be treated with antispasmodics such as hyoscyamine or hyoscine, which is bromide, or peppermint oil. Then, if they have mild cases of IBS-D, we talked about loperamide and bile acid suppressants such as cholestyramine, cholestyramine. Abdominal pain, still we're back to the antispasmodics, e.g. hyoscyamine or buscopan and peppermint oil. Then what about second line? There's secretagogues, linaclotide, lubiprostone. Lubiprostone is used less these days. Again, there are some black box warnings that came out. So linaclotide is really the thing that is used the most in this class. And for the ones with IBS-D, we just mentioned rifaximin and possibly low dose amitriptyline and relaxadine. So if the symptoms are persistent or the psychologic symptoms, then again, you look at it from that end. IBS-C, you can give tegaserod, IBS-D, allostatin, very third line, rarely used medications for this. So then SNRI can be given if you think now this patient, really has depression. It can modulate some of these symptoms. Then again, you talked about cognitive behavior therapy and hypnosis. So this is a summary of all that we talked about. And really, our talk was about the role of hyoscine in IBS. And you can see it's there. It's supported by all the guidelines, both by IBS-D and IBS-C. So in conclusion, I'll say again and again, do not forget the alarm symptoms or warning signs. Look out for them. Let's treat these patients right. Let's not miss anything major. Next, clearly there is the efficacy for HPV in abdominal pain and IBS. And 3 major clinical guidelines support the use of HPV for abdominal pain in both IBS-C and IBS-D. Thank you very much. I will now hand over to the moderator. Thanks.
Thank you very much, Dr. Murunga. That was a very wonderful presentation. I have plenty of questions on the Q&A, but before we get to our questions, could we please get Sanofi's Dr. Steve to tell us something about one of the products you have mentioned in your slides, and then we go to the Q&A.
Dr. Steve is just saying a word, then Daniel will do the product presentation.
Okay, all right.
Okay, thank you. Good morning, everybody. I'm Steve Defotika, medical advisor for French-speaking Africa and for Kenya. And I'm working with the teams on Kenya, Mildred, and the other ones. Actually, I'm based on Cameroon. And what I have to say is to appreciate and to be very grateful for this moment and for the topic, for the presentation of Dr. Murunga. And I appreciate and I give thanks to Kenyatta National Hospital and University of Nairobi for this topic and for this subject, which is very important. And I have learned so much after this presentation. That is all that I have to say. And Daniel will do everything, presenting the products and other ones. Thank you, doctor. Thank you, everyone.
Thank you, Dr. Steve, and thank you, our presenter, Dr. Murunga. Kindly, maybe you can stop your presentation so that I can share my screen as well. Thank you. Right. Can you see my screen?
Not yet.
How about now?
Not yet.
No. I think, Daniel, if your screen is not visible, you can just talk us through it.
All right. Just a minute.
While you're setting up the screen, could you please factor into your presentation some of the questions we have of whether hyoscine can be used in pregnancy and whether hyoscine can be used in breastfeeding?
Okay.
Yes.
Yes, I think this is something I can look into, as I also So I've actually shared it with the KNH team, so you can share on my behalf. Nelson and team, kindly share if you have it on your end. So good afternoon, everyone. As Nelson and the team share their presentation, my name is Daniel Gathu. I'm a medical sales rep working under Group Ethica for Sanofi, basically marketing within the regions of Kenyatta and the environs. So today, I'm just going to finalize on what Dr. Eric has presented for today. And my major focus is basically on the product Buscopan Plus and Buscopan as a whole. Maybe the first thing to talk about majorly is there's a reason why sometimes we focus some of these products, basically because we want this information and this knowledge shared by people who actually have been dealing with these conditions. And I think we've learned a lot from Dr. Eric. My sharp focus for today is why Buscopan, why not any other product? But with your permission from Kenyatta, I don't know if you have had the presentation yet. Kindly share.
Just give it a moment. I'm working on sharing it.
All right, thank you. So as we wait for that, Buscopan basically comes in two presentations. We have the Buscopan plain, which is basically a film-coated tablet of 10 mg of hyoscine butyl bromide. It's also available in the retail market. It's available within Kenyatta at the plaza. We also have Buscopan Plus, which is ideally the film-coated tablet of hyoscine butyl bromide, 10 mg, in combination with 5 mg of paracetamol. And basic indication, of course, is gastrointestinal, antispasmodic, and also acts as an anticholinergic. Thank you, the team. Thank you so much. So let's carry on. I think I did the introduction on this part. So this is how Buscopan looks like. And I've said this is one of the presentations we are discussing about today. Kindly, let's move on to the next slide. So basically, Dr. Murunga has really talked about the mechanism of action for Buscopan. And this is just a graphical presentation of what happens when there is food stress and, of course, abdominal cramping. And basically, Buscopan works to relieve that spasm. And on the lower picture, you can see what happens. And of course, the food bolus is about to pass through. And just a mention, this happens in about 30% of the population. So it's actually more common than you would imagine. To the next slide. So the difference and why we say Buscopan is more preferred than the analgesic is you want to address the root cause of the pain. And in most cases, when you are prescribing something that does not deal with the spasms, you are basically just preventing the pain from reaching the central nervous system. But when you have products like Buscopan, it does not mask the pain. It is actually an antispasmodic. It is going to relax the smooth muscle. Of course, you need something that is fast acting. It is seen to act quite fast. And of course, something that has minimal side effects. And that's Buscopan for you. Moving on. So we've talked about indications, and I think Dr. Eric has done a good job about that. Maybe to get to one of the questions that has been asked about pregnancy and lactation. Yes, we have available, although limited, preclinical data, and it shows no hazard. But of course, we want to have safety during pregnancy. So the usual precaution of the use of drugs within the first trimester applies. So for hyoscine butyl bromide, we advise you to use it cautiously when benefits outweighs the risk. And of course, take it with caution and administer it with caution for your patients who are breastfeeding, and of course for the ones who are pregnant. All right. So for dosage, this is basically dosage for Buscopan Plus, and I want to emphasize on the age of 10 years and above. Basically, you give 1 to 2 tablets 3 times a day. Of course, most people would want to give this with a bit of water, so not too much, just a little bit of water. What we want to insist on is you should not take more than 6 tablets within a day. To add to this, the Buscopan plain tablets are actually indicated from the ages of 6 years. It's a bit different because, again, the difference in the paracetamol. So you can give the Buscopan plain tablets from the age of 6 years, and they are also dosed at 1 to 2 tablets 3 or 4 times in a day. The number there changes slightly. Moving on. Yes, and my presentation ends there. Thank you so much to the team. We'll hand back over to the moderator. Thank you so much.
Thank you very much, Daniel. I think that has answered a few of the questions on the Q&A panel. So now we will go back to the presenter with most of these questions. So if I have to group them a bit, one of the questions we had was, how do you differentiate between IBS and food intolerance and food allergies, considering they tend to present with more or less the same symptoms? Dr. Murunga.
Yeah, thanks a lot. That's a very good question. And often patients ask me if they have a food allergy. And, you know, there are all these tests for allergy, which some of the blood tests for allergy are frankly quite useless because they'll show that the patient has allergies and intolerance to 15 different foods which don't affect them. But in general, when you're talking about food allergy, most of the symptoms, most of the patients will have pruritus, or rash. So it's not just bloating and all that. Those are not symptoms of allergy. So they should have a rash or itching when they eat certain foods, and then you know, they might have diarrhea, but and the history of atopy. Maybe they're asthmatic or they have atopic dermatitis or eczema, and so these are the kind of people where you start suspecting they could be having a food allergy. And therefore, in such patients, if you're suspecting food allergy, then I would normally send them to an allergy specialist where they can do appropriate testing, especially the skin testing, to find out if it's a food allergy. But again, this is not common. Food intolerances, things like lactose intolerance, those are more common and they may present with similar symptoms. But you know, usually with a good history, you can be able to suspect these kind of things. Thank you.
All right, thank you for that. An anonymous attendee asked, with constipation and a flat affect, would thyroid studies have been important in this patient? The example you'd given.
Well, I think what we've said is that this is a diagnosis. We want to make a positive diagnosis. You know, there are many conditions which, you know, you can think of which can cause symptoms similar to IBS. If there's something leading you there, yes, by all means, you need to test. Maybe they give other symptoms, like maybe they're, you know, like if you're thinking of hypothyroidism, are they, for instance, gaining weight? Do they have cold intolerance? You know, all those sort of things. I mean, this is a young man. At that point, are you really, you know, what's the demographic, you know, for this patient? So yes, if something is pointing you definitely positive towards that side, yes, by all means, it's important to test. But again, we're not going to test for everything that could be causing any of these symptoms. We have to try and work out a positive diagnosis, and that's why all these guidelines recommend doing that with the use of some of the criteria. And the nice one, as you saw, is the simplest. Thanks.
Thank you. So with regards to the gut microbiome, do probiotics and prebiotics have any role in the management of IBS?
Excellent question.
Dr. Murunga, you've gone mute again. Hello, Dr. Murunga.
And but it's not something that we often prepare for that. Having said that, sometimes I think that could be a role.
Sorry, Dr. Murunga, we didn't hear your answer
Yes.
to that question. At some point you were mute. Could you please start again?
Okay. Yes. So I was saying that in as much as the microbiome has been found to have somewhat of a role in IBS, the agent that has been found to help with that is rifaximin. Because of maybe there could be some bacterial overgrowth associated with those patients. But as far as probiotics and prebiotics, no, we don't have a very strong role for those. We don't see them in the guideline. There are probably some small studies that have led to the production of certain things called neurobiotics and all that, which seem to maybe help with the mood. But honestly, I don't think it's really something that has been proven in good RCTs. Thank you.
Okay.
So no, I don't give that primarily for IBS.
All right. Now, in relation to that same answer, two other questions. The first one is, can IBS be interchangeably used with small intestinal bacterial overgrowth as a diagnosis? And how long should you repeat, after how long should you repeat rifaximin in a patient who already got rifaximin the first time?
So if the person improves with rifaximin, they get better, and then they're doing okay, then after a while the symptoms come back. In that case, you can repeat. So it's not a duration, it's just a recurrence of the symptoms that makes you want to repeat. And for the first question, no, SIBO, or small intestinal bacterial overgrowth, is a different entity from IBS. There could be overlap in the symptoms, but bacterial overgrowth is basically what it says. If there is, a lot of times you'll see it in patients with the slow GI transit, maybe prior surgeries, prior abdominal surgeries, or blind loop, people who've had, Whipple's and other surgeries, or diabetic patients, or even patients without risk factors, then they might have SIBO, but it's a totally different entity from IBS.
Okay, all right, thank you. Is there any relationship between IBS and alcohol? Does alcohol predispose to IBS or make it worse?
I'm not aware of such a relationship.
Oh, okay. Another set of questions is IBS in pediatric population. Is it a diagnosis you can make in children? And is management more or less the same?
Well, I try to limit myself to the area that I practice, so I generally do not see children.
Okay.
I would say teenagers, maybe you could call this 15-year-old a child. I mean, with teenagers, it's more common. With younger children, I believe it might be there, but I do not want to wade into that side of things because I don't know enough about that.
All right. There's a gentleman here who asked about the alarm signs according to the NICE criteria, which I think you had mentioned. So I'd refer him back to the slides unless you want to go through them again.
No, I think we've addressed them.
Yes.
Yeah.
Somebody has asked, what is the role of Libraxin or Librax? Do you have any response to that?
No, I've never used it. I don't know what that is.
Me neither. All right.
Does anyone know? I don't know.
All right. IBS, can it manifest as low back pain?
No, I mean, I'm not aware of IBS manifesting as low back pain. That just seems unrelated to me.
Okay. Managing the excessive flatulence or gas in IBS, what do you suggest?
Well, in general, if there's a lot of bloating and all of this, I would say that's part of the global symptoms. We talked about antispasmodics for that. But if there's IBS-C, for instance, if you treat the constipation, a lot of that bloating and gas should improve. Same thing with IBS-D. if you're able to manage the diarrhea, if you give the rifaximin and all that, I think to me I would still go towards those other things that managements that are considered first line, especially for IBS. And one of the things that we talked about is low FODMAP. Those are foods which are fermentable, and they will definitely cause gas. So if you can avoid those, that I would say would go a long way in treating the gas, the low FODMAP diet. If it's bad even with that, and you need to use things like simethicone, just sometimes I do those sort of things, or some of those other combinations of that, maybe for 2-3 days. But in general, the diet would be the way forward.
Okay, thank you for that. There's another group of questions which I thought should be addressed. Now, in patients who have IBS and who tend to keep away from multiple foods, how do you in practice stop them from restricting their diet too much, considering in their mind it is the food that is making it worse?
Yeah, I think it's just talking with them, like we talked about they might stop so many foods that makes their life miserable. I think I'll try to talk to them about the low FODMAP diet, and then tell them to just try and restrict for a month or two, and then try to come back, because a lot of patients, they've been told elsewhere, stop this, stop that. But I think it's just part of what we talked about, having a long-standing relationship with patients and being empathetic and understanding. You can discuss a lot of these things and help them through it.
All right. So the treatment of IBS, considering it is lifelong, how long do you put them on medication? Is it for weeks, for months, or do you put and stop when the symptoms resolve?
Yeah, I wouldn't really say that the treatment is lifelong, because some of these patients improve. Some of them, like you may do that rifaximin and they're better and they can do just the diet. So with these treatments, I just normally give the usual, if it's something longer term, just some of them might be PRN, like the antispasmodics. Some of them, they require something longer term for very bad symptoms like constipation. I'll do it for a month and then see how it goes. So yeah, I would not really call these treatments lifelong.
All right. So it is, you put on treatment, when the symptoms resolve, you reassess.
Yeah.
All right, thank you. Somebody wants to know which PEG would you use in practice, and how would you prescribe it for IBS-D?
Okay, am I allowed to use brand names a lot? I don't know. But anyway, yeah, I think there are different formulations. There's sometimes you use Movicol and all of that, and I might have them start with once a day, then increase to twice and 3 times, that sort of thing.
Okay. Can IBS patients take wheat products and milk products? I think you've already mentioned about milk. Wheat products?
Yeah, that's part of the FODMAP that, we tell them to reduce the wheat products and all of this. Again, just for limited periods, as we've discussed about how to manage the diet. It's not that they cannot take the foods.
Okay. Is there any role for methylamine or mesacol in treatment?
No.
Okay. Milk products, I think you have very many people congratulating you on a very good presentation. So congratulations, Doc, on a very good presentation.
Thank you very much.
Patient responds well to amitriptyline 12.5. How long can it be safely used in IBS?
Usually I try to encourage people, if it seems to have made a big difference, I encourage people to use it for maybe 9 months to 1 year, and then kind of wean off gently, maybe even go to half tablet, that sort of thing. So that's typically the duration that I discuss with them. Because if you use it for just a month and you're much better, if you stop it, then you could get a rebound of the symptoms.
Okay, thank you. There are 2 questions here from 2 attendees that I would prefer to refer to another physician. So there's Sophie, who has H. pylori. Says she never eats anything, has serious pains throughout the day. I think that might better be sorted by a gastrophysician in person than in this group. And there's another one who has a 7-year-old who says the 7-year-old has what sounds like stool incontinence. I would refer you to a pediatrician or a gastrophysician in the pediatric area. That might be better sorted from there.
Agreed.
Yeah. I think that's the bulk of the questions we had.
Thank you.
Thank you very much, Dr. Murunga. That was a very insightful topic. All right, I will hand it over back to Sanofi to give us a conclusion. Sanofi, Dr. Taker.
Okay, thank you, Dr. Amanda. Thank you, Dr. Moringa. Thank you to everyone for participation. Thank you for your presence. Thank you for your time. And I think that after this presentation, we have many baggage to go on the way of gastrointestinal problem, and we have a solution proposed by Sanofi. And at this, at the end of this presentation, at the end of this webinar, I think to say one more time, thank you to Kenyatta Hospital, and thank you for University of Nairobi. Thank you, Doctor.
All right. Thank you very much, everybody, for your attendance. Thank you, Sanofi. Thank you, Dr. Murunga. Thank you, KNH, for this opportunity and this platform. I think from the question and answer section, there are many more topics in the gastroenterology area that you could set up for us, primarily including H. pylori. So back to the KNH research team. Research team is okay with us concluding the meeting. Mr. Okinda?
Yes. Thank you very much, Dr. Ngolobe and Dr. Murunga for such a highlight. Dr. Murunga, hopefully we'll have you again. Another separate topics. I think this is one of the most sought out topics. We've had attendance of up to around 2,200, and that's quite a big number.
Thank you. I'd love that. Yeah.
Thank you very much. And back to you, the KNH team and the Mwai Kibaki. We are so glad that we hosted this. As we always share, the CPD points will be shared to your various platforms as guided by your board requirements. So that one will be sorted as usual. We look forward for more webinars. Kindly check out on upcoming webinars in your email addresses. And again, we'll develop different posters for other webinars. Thank you, Dr. Ngolobe, again for moderating the session. We appreciate you from Mwai Kibaki Hospital. We are so glad that you represented this so well. Otherwise, until next time, have a lovely evening and good morning to those who are in other countries. Thank you very much.
Bye, everyone.